Hi everyone, thank you for joining us for this really exciting video on best practices for transseptal in left atrial appendage closure. We are very excited to have Steve Filby, the Director of the Cardiac Cath Lab and the Interventional Fellowship at University Hospitals in Cleveland, Ohio. So take it away, Steve. Thank you for joining us.
Thanks for having me. It's a great topic for discussion. It's an important topic because transseptal procedures, transseptal puncture is increasingly being used, particularly for structural interventional procedures. So there's quite a utility for this technique. And there are several pitfalls that we're going to discuss and things that we should do. So this is a best practice talk for transseptal puncture. Here's our presentation outline. We're going to talk about transseptal puncture equipment, a workflow, and the way that I perform the procedure. We're going to talk about transseptal related complications, go through some challenging anatomies, and wrap up with a few conclusions. Let's talk about the procedure. This is the way that I perform a transseptal. It's there are different ways of doing this, but I perform my transseptals using ice, and I do CT planning to understand the anatomy. So planning the procedure starts the procedure starts with planning the procedure. We prep both groins. We obtain access, usually in the ipsilateral leg, in the right common femoral vein. Place an 8 French sheath. It has a more linear trajectory if you're coming from the right side, but you can use the left if the 8 is occluded, or if the right side is occluded, or if there's some prohibitive anatomy. And then if you use ice to do your transseptal, you will need to get a second access, and typically we'll get access on the same leg, ipsilateral leg, about 3 centimeters distant from the first. Now I favor ice for visualization of the interatrial septum because it allows us to get more visualization of the inferior, and particularly the posterior aspects of the interatrial septum, whereas T, which is perfectly fine and suitable for visualizing the interatrial septum for transseptal puncture, is better suited for perhaps the more anterior and superior aspects of the interatrial septum. So being an operator who does a lot of Watchman's left atrial appendage closure device, then I favor ice for this reason, because mostly our transseptals are performed in an inferior posterior location, of course depending on the anatomy, but typically in that location across the interatrial septum. So we administer heparin. Now some people administer heparin prior to puncture. I administer heparin prior to puncture. Some people administer heparin after they cross the septum. But by and large, I will administer heparin after I've obtained vascular access. I use a Baylis and VersaCross system for transseptal puncture, which is a radiofrequency system we'll talk about. The O3 wire goes up to the SVC. We do a sheath exchange. We put the transseptal sheath over that O3-5 wire up to the SVC, remove the wire, and then we're going to rotate the handle of our transseptal sheath to around the 4 or 5 o'clock position. It varies, of course. No two hearts are alike, and people have rotated hearts, so that gives you a ballpark for starting with your drop, and you pull the equipment down until it drops. Literally, it will drop into the fossa, so you will have both a visual and tactile feedback as the tip of that catheter drops into the fossa valis. You must see tenting. Tenting has to be visualized. You have to see the tip of that transseptal sheath making contact with the interatrial septum before you puncture. And then, of course, as I mentioned, we puncture with application of RF energy, and we deliver that over 1 second. I mentioned that I plan my transseptals using CT. I find that this is very helpful, particularly with left atrial appendage closure, because it enables you to find that trajectory whereby you're going to cross the septum and go into the left atrial appendage in a coaxial fashion. And coaxiality is very important with left atrial appendage closure for appropriate seal. And here you see this is multiplanar reconstructed images, three different planes, axial, coronal, and sagittal, with a angiographic representation in the lower right of what the appendage would look like with dye injection. And you can see that this is a chicken wing, an anterior chicken wing with a vertical neck, and I want to place my device into the neck of this left atrial appendage. In so doing, what I have to do is get very low in the septum. So I wouldn't understand that or appreciate that unless I saw these CT images for planning the procedure. Takes 2 minutes, saves a lot of time. You also understand the interatrial septum and whether or not there is thin fossa at the location where you want to puncture. So for instance, if I saw this anatomy, but the area of the septum that I would like to cross was unfavorable, thick, lipomatous, but perhaps there was a thinner aspect in the mid part of the septum, maybe then I would use a steerable sheath. And Boston Scientific certainly has a very nice TrueSteer sheath that's available for this application. So it does affect the equipment, it affects your planning of the procedure. Having this information going into the procedure makes the procedure more efficient and a more mature and safer procedure. Always use micropuncture with ultrasound guided access for venous access. There have been a number of studies demonstrating the safety profile of this, though there is a learning curve. It's very important to obtain access using ultrasound guided access. And here's a picture of this, the tip of the Baylis wire. As the wire applies energy and goes through the septum, it makes a atraumatic pigtail loop. Many operators still use a Brockenbroad needle, which is shown in the panel on the right. But I favor the Baylis system because I think it's safe. It's a safer system, particularly with aneurysmal septal anatomy. I'm going to take you through some of the some pictures from a transseptal procedure. So here we see an 035 wire being advanced from the femoral vein into the SVC. And you see, if you can see, appreciate an ICE catheter that's positioned in the right atrium. My VersaCross catheter is then going over that wire, and I'm placing it high up into the SVC. And then I'm going to make my descent down with my hands in a 4 to 5 o'clock position. I'm going to begin the descent. Oftentimes you'll actually have two tactile drops, one from the SVC into the right atrium, and then in the right atrium into the fossa. Prior operators had done this procedure using just fluoroscopy, although that's largely abandoned now in favor of imaging, which really can limit the amount of complications dramatically. This is the hand position that you would hold. Of course, this is a Brockenbroad needle on the left, but a picture of me holding the VersaCross catheter. And you can see both of these devices have an arrow as part of their handle apparatus. That arrow is what I'm indicating would be pointing at a 4 to 5 o'clock on a clock face in terms of positioning for your initial descent. You might make small adjustments as that catheter interacts with the atrial tissue and as you're visualizing the tip of the catheter under TEE or ICE. The puncture location, the place where you're going to cross the interatrial septum, really depends on what procedure you're doing. So for instance, we are speaking about a left atrial appendage closure, and I indicated that most often I'm going to be utilizing an inferior posterior location. But for instance, if you are doing a MitraClip procedure, you may favor a more superior and often a more superior or even a superior and anterior location for your transseptal. This is a nice central figure from a JACC cardiovascular intervention article done by Mahmoud Okuli, which goes through some of this in more review. When we're looking at ICE images, the anatomy in the echo sector helps me or helps the operator to determine where you are in terms of anterior, posterior, superior, inferior. So to be precise, here we see an image on the left that shows the interatrial septum, and below we see the mitral valve. We know that the mitral valve is an anterior structure. So as I'm making my descent, and if I see my catheter interacting with the interatrial septum at this location, and I want to be posterior, I know that I need to clock my catheter to get to a more posterior location. And by in opposite, here we see a picture of the interatrial septum, and in this echo sector we see the descending aorta. We know that the descending aorta is a posterior structure, so I might be too posterior if my catheter is engaged with the atrial septum at this location. So we use the anatomy within the echo sector of our ICE image to determine the location of our catheter as we make this descent. And here I see the catheter is in an inferior location. I have my ICE probe is looking at the tip of my catheter. I'm going to externalize my needle very slightly just beyond the tip of my catheter. Here you see the catheter on the left panel in an ICE image. that is interacting with an inferior aspect. So this is superior and inferior across the inner atrial septum from the top to the bottom. And in the far field, I see a pulmonary vein. So I know that I'm sort of mid-posterior, and this is a good location. I'm tenting the inner atrial septum. I'm making contact so you can see that this is bowing forward. And at this point, I would then call for, once the needle tip is engaged, I would then call for delivery of that RF energy. And over that 1 second in which that energy is being delivered, I will externalize the tip of my wire, and as it does so, you'll see it make that loop that it's intended to make into the left atrium. And here we see another picture here as the wire is going across. Now, once the wire enters into the left atrium, I do take some care to try and put that wire tip into the left upper pulmonary vein. Not many operators do this, but I think it's important to allow your wire to have as much running room as possible.
Yeah, that's a really, sorry to interrupt, that's a really great point. I think two things you said, just to reiterate, is that point to put it in the pulmonary vein. I think that's essential for all these transseptal procedures. I'm glad you said that. And then two is to visualize the tent. I mean, particularly with those people using, you're obviously a very talented ICE operator and can get some beautiful pictures. But sometimes people are kind of sort of guessing, but that's a dangerous game to play. TEE or ICE, really make sure you visualize the tent. That's so critical to know where you're
Yeah,
at.
there should be no, Elliot, there should be no guesswork at all.
Yeah.
If you can't see it, then you need to take time or call someone else in to help you with it.
Yeah.
But don't guess. When you guess, you get into trouble, and frequently that runs into misadventure followed by a pericardial drain.
Which I think you're going to talk about.
So that's a good segue into our next segment for this talk, which is transseptal related complications. And pericardial effusion, and specifically cardiac tamponade, is the dreaded complication of this procedure, the incidence of which varies based on published literature, but probably around 1%, maybe slightly less than that, as we've had the advent of more sophisticated imaging to support this procedure. If you do cross into an area of the septum, perhaps it's more posterior than it should be in the membranous aspect of the septum, don't pull that catheter back immediately. Reverse, drain, reverse, call for help, call for backup. If the bottom line is that you really want to prevent this if at all possible, visualizing the tent before you puncture. And if there is excessive tenting and you're using a Brockenbra needle, perhaps consider using a radiofrequency technique, because it allows you a less traumatic puncture of the inner atrial septum, especially when those septums tend to give. They'll give, and all of a sudden give, and then you're instrumenting the posterior wall of the heart with a needle or catheter. So think about using an RF system if there is a very aneurysmal septum. That's one way that you can avoid this altogether. Here's a situation in which the Baylis wire crossed into the left atrium, and the fellow with whom I was working then delivered that wire very briskly, and it went inadvertently into the left atrial appendage. So you can see with pigtail angiography that it literally lacerated the left atrial appendage, and you see contrast then flowing into the pericardial space. So even though the Baylis wire is a very, as I mentioned, an atraumatic wire, if it is delivered very quickly or hurriedly, particularly into the left atrial appendage, which is a very thin-walled structure, on average 0.6 millimeters in thickness, so that tissue is translucent ex vivo. If that wire goes quickly, it can deform and cause shear injury to the left atrial appendage, which is what happened here. So in this particular case, well, since we are already into the appendage, I quickly delivered a device, because we're literally plugging the hole, and then I drained the pericardial space. And you can see a pigtail drain here looping or wrapping around the heart, and this is the appropriate position of a pericardial drain, is what you would expect to see. Aortic root puncture should be a never event, and we saw this more often with fluoroscopic guided procedures, but with TEE imaging and ICE imaging, this is something that should not happen. But it can occur if the puncture is too anterior, or if the needle slips, perhaps with an insufficiently experienced operator. If you do cross into the aorta, do not advance the dilator. Evaluate for tamponade, obviously. If it's only the needle, you may be able to withdraw it, but check pressures if there's any question. And if you're puncturing in TE, it's important to puncture in the short access. If you're puncturing with ICE, you don't want to see the aorta, which is an anterior structure, while you're puncturing the membranous septum. So you would clockwise rotate and get to a more posterior location, and of course, don't puncture unless you see tent. Air and thrombus embolism are also reported, although fairly uncommon for transseptal puncture procedures, but they can occur. If it is thrombus, then you want to make sure that you are fully anticoagulated with heparin, and obviously you want to make sure that you've given heparin either shortly before you puncture or shortly after you cross into the left atrium with a target ACT greater than 250 seconds. If there's thrombus that you note and you can aspirate it, thrombus aspiration has been reported to be an effective technique. If there is a large thrombus formation, consider other options that may effectuate that removal. Obviously, prevention is prevention is very important, so giving the patient heparin is important, and making sure they have appropriate ACT for anticoagulation. Bubbles can cross as well, so you want to be very vigilant and diligent about de-airing and flushing, particularly if you are operating in a patient who has low left atrial pressure. So if you get into it, and I always check the left atrial pressure when I cross over, but if you have a patient who's volume depleted, a younger patient tend to have lower left atrial pressures, they can aspirate air through the TUI, even through closed large bore TUIs, can air be aspirated if there is vigorous coughing or vigorous inhalation against the system. This is an example in which that occurred. This was an elderly female who had atrial fibrillation and actually had been admitted prior, maybe a few weeks prior, with an inferior STEMI, very complicated course, had cardiogenic shock, and upon arrival was markedly anemic and undergoing also a concomitant GI bleed. So the patient got resuscitated, transfused, and ultimately got revascularized with PCI of the right coronary artery, and then came to see me for left atrial appendage closure, given the need for antiplatelet and anticoagulant medications in the setting of a recent GI bleed. So a good candidate for a Watchman device. Well, as you may or may not know, the left upper pulmonary vein is surrounded by the phrenic nerve. The phrenic nerve runs right along it. So as I placed my wire into the left upper pulmonary vein, the patient then vigorously began coughing, and really rib-splitting coughing. This was not just your average 1 or 2 bouts of coughing, but this patient was coughing violently, and I couldn't get her to stop. We proceeded with the procedure, and if you can note here, if you're careful, what you can see here are small air bubbles here. I don't know if that shows very well, but I think you certainly can appreciate the fact that her hand is over her chest. So this is sort of a fluoroscopic Levine sign here. She's clutching her chest, having chest pain. And what we saw was inferior ST segment elevation. Many times when air goes into the left atrium and embolizes from the left heart, it'll go either in the cerebral vasculature and cause a stroke, or if it goes down one of the coronaries, it'll go down the right coronary artery because the right's an anterior vessel. And in this is exactly what happened here. And if it's a young, healthy person, so I've had one of these that occurred with a PFO, and with a tincture of time and maybe supplemental oxygen, it goes away and resolves. But in this situation, the patient got increasingly sick. So she was going into shock. We decided to do coronary angiography. And here's what you see. You see the stents that were recently placed in her right coronary artery, but unbeknownst to any of us, including the patient, she had critical in-stent restenosis in the proximal aspect of the stent, such that air was hanging up and unable to go down the vessel. So air was hanging up, had been embolized from the procedure, and you can see that column of static air that was unable to be washed through her native circulation because of the fact that she had that critical in-stent restenosis. So we did balloon angioplasty, and then immediately there was resolution. So you can see TIMI3 flow now with the vessel. We did IVUS, demonstrating severe in-stent restenosis at this location, and then of course, then placed a stent and had a really nice angiographic result, and that patient went home the next day. Here you can see the left atrial appendage closure device and the right upper field. So it does happen even if you're meticulous, and I was talking to some physicians last night, some EP physicians. We do our left atrial appendage closures under conscious sedation, as my story would have indicated, but this physician was a very experienced EP doctor and had one happen with a patient under MAC or general anesthesia as well. So you have to be very meticulous about air and very meticulous about flushing the catheters. ASDs occur because we are creating an iatrogenic ASD, but really they often close on their own. I mean, I can't think of one that I've actually had to close, although some have reported closing this, particularly after mitral clip procedures. And if it's very large, perhaps greater than 8 millimeters, it might be reasonable. But only about 15% of those will persist upon follow-up, and whether or not these are hemodynamically significant is a place for debate. Now, most do not, and as a matter of fact, there are, as you may know, heart failure trials in which we're creating ASDs to offload the heart. So the bottom line is they mostly close. You don't have to worry about them. If they're quite large and you think they're hemodynamically significant upon follow-up, you can consider closure.
Yeah,
Let's move
great.
into.
Oh, sorry, I was
Yeah.
just gonna think. Yeah, that's very true. I think the one group of people I've seen it is with the larger iatrogenic ASDs and like for a MitraClip, like you mentioned, perhaps with concomitant severe TR. Those are, I mean, other than that, yeah, I mean, I can't remember closing a left atrial appendage closure ASD. And another point I just wanted to quickly highlight, which I loved your case with the fellow induced perforation with the wire. That illustrates two really important points. One is don't put the wire in the appendage, even though it looks like this soft, thing that isn't going to cause problems. And then the second thing is that was a really brilliant call to just close the appendage, because that's where your perforation is, and realistically you're really reducing flow. I mean, as we see with a good closure in a post LA angiogram, there's really diminished flow into the appendage, so you're causing kind of stasis within the appendage and aiding your ability to deal with that tamponade. So that was a very quick thinking and a really nice maneuver.
Yeah, thanks. I mean, there are a couple of things from that case. One is, if you're the first operator on a case, you really have to be the smartest person in the room many times. You ultimately have to be the one to recognize that, and I was the only one to do so in that particular case. As a fellow coming out of training, I reinforce this case to my fellows to be able to recognize those complications, because if you can't recognize it immediately, you can't take care of it immediately. But we could get that device in faster than I could drain the pericardium, because we didn't have a pericardial centesis kit up. I mean, all that stuff is at hand. It's at the ready. But nonetheless, I got that device in probably within 2 minutes, and then then that allowed my nurses to get the chest prepped and ready for the drain to be put in. Let's talk about some challenging anatomies. Enlarged atria is something that you're commonly going to encounter, and I always visualize the size of the atria based on the imaging that's at hand, whether it be a TEE or a CT, and I sort of plan the curvature that I'm going to be putting on my trans-septal sheath based on the anatomy that I see. Certainly, if you are trying to reach the inner atrial septum and you're not making good contact or tenting, rather than trying to make the catheter work in a way that it won't, and certainly trying to cross the septum when it's inappropriate to do so because you don't have good tenting, you take the catheter out and put a more aggressive curve on it to make sure that you can make contact at the end. This is an example of that, and you can see that this is a VersaCross catheter, which holds good memory, by the way, and I'm making a primary curve, but let's say the patient has a tortuous venous anatomy. I might make a secondary curve on that catheter as well to really reach and get to where I need to in terms of making contact with the inner atrial septum. I also will use long sheaths for this reason as well. So if I place a wire up, or if the patient gets on the table and their vertebral column is very tortuous, well, I know that the IVC is going to follow, by and large, is going to follow that anatomy, so I'm going to have a very tortuous venous system. So I might use a longer sheath in that situation to straighten out the IVC, or I might put a secondary curve as I do here in this illustration. Often we also run into thick septums. These are patients who have lipomatous septums, or perhaps they've had transseptal procedures performed in the past, an ablation or whatnot, and they have thick, scarred, or calcified septums. The RF systems have been very successful for me. I think that these septums are more resistant to a Brockenbrough crossing than it is with in a radiofrequency energy system. But if you do get across and you can't get across with your equipment, then use a balloon for an atrial septostomy. And usually what I will do is use a 5x40 or 6x40 balloon and just dilate across the interatrial septum. Once you do that one dilation, that's typically all that's needed. Take your balloon out and your equipment should pass easily. Using just the dilator, so if you're going in with a delivery system, and let's say you can get the transseptal sheath across, but you can't get your double curve sheath, sometimes just going with the dilator can give you enough running room to get the rest of your equipment through as well without using a balloon to dilate the septum. And here's another example of just how using the CT images in advance of your procedure can give you a lot of information, so you can appreciate the thickness of the septum based on CT as well as you can with TE. But it's worth taking a minute just to look at, see what you're getting into, so that you have that equipment and you can forecast problems that may lay ahead. Aneurysmal septums I've already alluded to. These are hypermobile septums that can have quite a bit of excursion. Well, why does that matter? Because as you're pushing upon the septum gives and gives and gives and gives, almost to the point where you can get to the posterior wall of the left atrium, and then it all of a sudden gives in such a way that you end up advancing hurriedly across the septum and instrumenting the appendage or the left atrial wall, and you can cause inadvertent injury and cause tamponade in that situation. So this is another example of where the radiofrequency system comes really comes in handy, and perhaps is safer than the Brockenbrough technique for crossing. And here we see an illustration of that, where you see a lot of pressure being put across the interatrial septum, and it sort of gives all of a sudden. Another reason to put your wire in the left upper pulmonary vein, because it really gives you a lot of running room. If this wire, if the curved part of this wire were just in the left atrium, you can understand how by the sudden or brisk movement that goes through the interatrial septum, that the tip of that catheter may be instrumenting tissue that can cause injury. Pacemaker leads are another obstacle that we face with this procedure, and here you see a person with just an inordinate amount of leads. I mean, this is not something that you'll see commonly, but you will see patients, particularly with left atrial appendage closure or with mitral clip procedures, you're going to see patients who have pacemaker or ICD leads. And you want to avoid those, obviously. You don't want to have the patient come out with another procedure that they have to get something fixed. So making time to take the time that you're not interacting with them as you make your approach, as you make your descent down across the interatrial septum. I take time. I might, we don't have a biplane lab, so if I'm making my approach under a PA projection, then I'll swing my camera LAO to give another perspective to make sure that I'm not interacting with the leads as I come down. And here you see an example. And this is why I go up with the VersaCross wire. Although you can go up with that Bayless wire for your transseptal, frequently it will interact with your leads if you do so. So oftentimes I'll use a multi-purpose catheter to carefully direct my wire away from this equipment up into the SVC. And if there's a tangle or crossing of wires, I might begin my descent a little bit early, and I certainly want to avoid getting up to the snare of those wires so that I don't engage with those wires at all. So transseptal puncture is increasingly performed to support a variety of both EP and interventional cardiology procedures, particularly structural procedures. Imaging with fluoro and ice or TEE is essential for a safe procedure, not just fluoro alone. Pre-procedural planning also may be of benefit for this procedure, and I've pointed out a number of aspects for that. I think that RF energy systems, and there are a couple of different RF energy systems out there, allow for a more precise puncture and may be safer with certain septal anatomies. Tenting must be visualized prior to puncture. And be careful with stiff wires in the left atrium. Take time to put your wire in the left upper pulmonary vein. Aortic root puncture should be a never event, but you are going to see pericardial effusion. So you have to be comfortable with pericardial drain. Have one at hand. If you're doing a transseptal puncture, that equipment should be at the ready, and your staff should be educated as to how to quickly bring those patients to pericardiocentesis. And with that, we can talk some more, Elliot, and have some more conversation. But that's the conclusion of my talk.
Yeah, that was a great talk. We really appreciate it. That's a really, tour de force review of that in a short period of time, with really covering everything. I had a couple of questions for you that just were odds and ends with left atrial appendage closure. One is, since you're doing your procedures with ICE guidance, what are you doing for your ICE crossing? When you're moving your ICE catheter into the left atrium?
I use a single transseptal technique. So I will cross the interatrial septum put the Baylis wire in the left upper pulmonary vein. I then take my VersaCross catheter out, leaving my wire up. I go in with my double curve sheath and I dilate the interatrial septum with the sheath. And then I pull the system back into the IVC, and I have a technique where I flex the catheter. Typically it's an anterior flexion, but flexing toward the wire under fluoroscopy, and slide that ICE catheter along the wire into the left atrium. And then, of course, we bring the fixed curve or the double curve sheath along the wire, and the rest of the procedure is performed in a conventional fashion. On rare occasion, we would use double transseptal, but we've also described a couple of ways to get that ICE catheter across in situations where you've had trouble getting it across upon the first or second or third try. One of which is a snare technique, which we've described and it's been published in Structural Heart. That involves using a gooseneck snare, where you snare the tip of the ICE probe and literally drag it along. That puts a lot of pressure, and you have to be pretty coaxial in order for that to be effective, and the snare can sometimes get tangled with the wire. So largely we've abandoned that. Our go-to technique now is what's called the double wire technique. And so the double wire technique involves placing a second stiff wire in the left upper pulmonary vein. And the concept is, by having two wire systems across the interatrial septum, if there's macerated or redundant interatrial tissue, it tents open that septostomy and allows a pathway through which you can deliver your ICE catheter. And that basically, in a stepwise fashion, is taking the fixed curve or double curve sheath with its dilator into the left atrium, taking the dilator out so that the sheath is now pointed to the left upper pulmonary vein. Your Baylis wire, of course, is in the left upper pulmonary vein, but your sheath is now in the left atrium, pointed there. Taking the dilator out and then going in with the second stiff wire, an Amplatzer wire or something similar to that. And then that wire also goes in the left upper pulmonary vein, and you then withdraw your sheath back into the IVC. Now all you have across is two wires, and then you repeat that same series of events, that workflow where you identify under ICE where the wire is transecting the septum, flex to the wire, and confirm that you are on top of the wire and aligned with the wire in both the PA and a separate LEO projection, and then slide the ICE probe along the wire. And we've been successful in at least 80 to 90% of cases when we've used the double wire.
That's a great idea.
There's a third technique, actually, and that is called the probing technique. Now, we weren't the original ones to describe that, but it has been described and it's in the literature, and it's a pretty neat technique as well. The probing technique involves using a multi-purpose catheter in a woolly wire, and you basically come down on the interatrial septum as you would cross a PFO or an ASD with a multi-purpose catheter, and you come down to where the wire is, and then you start probing with your woolly wire, and you slide your wire along the stiff wire Then you bring your multi-purpose catheter along that over that wire. You take the woolly wire out, so now you have a catheter, hopefully in the left upper pulmonary vein, but at least in the left atrium. And then through that catheter, then you put a stiff wire. You take the catheter out, and then you deliver a long 8 French sheath. Of course, this involves putting the ice probe ultimately through a long sheath. The long sheath could be a versicross sheath, and you just take the introducer out afterward. That allows delivery of the ice catheter into the left atrium. So you're literally having a sheath deliver the ice catheter, but you get your sheath in first, take the introducer out, and put your ice catheter through the sheath. So those are the techniques that I'm aware of to facilitate passage of the ice catheter across the septum in situations where it's difficult.
Great, yeah, that's definitely a lot of different tricks to have in the tool bag. How frequently and in what circumstances are you guys using TrueSteer? All the cases, select cases. What's your kind of workflow for the new sheath?
We plan all of our procedures by and large with CT. If it's a prohibitive renal function, we'll do MRI. Or if they have a device that's incompatible with MRI, under that circumstance, we'll use TEE. So we have a good idea of what the anatomy looks like going into the procedure. We will have device selection already made, that decision prior to the patient going to the table, and we'll have a good idea of what equipment, and that includes whether or not to use TrueSteer or not. Now, our hospital, because of the uplift in price, has asked us to reserve these on an as-needed basis, so I'm using them selectively, and mostly for anterior chicken wings that have a vertical neck that, like I demonstrated in the slide before, where I need to get very low in the septum, but perhaps the septal anatomy is prohibitive for me getting across there. Or if the area that I want to puncture, based on CT imaging and NPR reconstruction, if the area that I want to puncture is unfavorable and I have to puncture it at a higher, more superior location, I'll consider the TrueSteer no matter the anatomy of the appendage.
Yeah, that's a great. I like your idea. And I think the chicken wings are where we're using it the most too. Kind of a similar situation. Not as much because of a hospital ask, just because of a miserly approach by myself, I guess. But we're using it just occasionally for complex anatomy. But yeah, I really do think that your point about the trans-septal that doesn't necessarily turn out the way you plan it out from imaging, because sometimes it's not quite as easy to tell the thickness of the septum, whether or not you can get certainly low, and you're not predicting the interactive forces or the course of the IVC. So sometimes you can't quite get as low as you want, and then it's a very helpful product. Well, that was a ton of information, very helpful. Thank you so much for doing this. We appreciate it. The whole Murmur community will get, I'm sure, lots of views, and if anybody has any questions or comments, I'm sure they'll direct it at us through the app. But thank you very much.
My pleasure. It was great being here.